All right. So again, welcome everybody. I am Crystal Flores, Assistant Education and Meetings. My position is Assistant Education and Meetings at the California Physical Therapy Association, and I will be your moderator for this presentation. Again, thank you for joining us for our AI-enhanced clinical reasoning and remote therapeutic moderating session with CPTA member Hoda Salsabili. So today's schedule is just still going to be a live presentation for us that will end at around 8. After the webinar ends, the course evaluation will be emailed to you all, to all paid registrants who have completed the evaluation, and you will all be receiving 2 hours of CEUs. Just as another reminder, this webinar will be recorded and the video will be sent to you by tomorrow afternoon. So just to make sure everybody's comfortable, please make sure to mute your audio, and just to minimize background noise or any unexpected noises that might be happening during the presentation. Also, please check your screen names on your video. We want to make sure your preferred first name followed by your registered last name, just to help check with attendance and calling on you to participate. And if you need help changing your screen name, please message me in the chat. Now let me tell you a little bit about our invited speaker. You'll find her expanded bio on our CPTA website. So, Dr. Salsabili has completed 2 postdoctorate fellowships where she's focused on AI applications and diabetes rehabilitation. And currently, she is an assistant professor in the Department of Physical Therapy at Samuel Merritt University. And I just wanted to give another welcome to our speaker and thank you for sharing all of your amazing knowledge with us. So, yeah, let's get started. I'll pass it over to you.
All right. Thank you, Crystal, for introducing me, and thanks for everyone for being here. I'm Dr. Salsabili. I'm an assistant professor at the Department of Physical Therapy, Rehabilitation Science at Samuel Merritt University. And I did multiple webinars about the AI. This is the 3rd time I'm here. This one is about the AI-enhanced clinical reasoning in remote therapy monitoring. This is kind of like a build-up of my recent kind of research also around educating the use of AI for both like in a simulation setting and also about the like in classes as well as a part of this presentation, and also like how AI can enhance the clinical reasoning and in the remote therapy monitoring. All right, so what is the big message that I'm going to transfer tonight is the use of AI is technically is for transforming data into the actionable clinical decisions. And how does that happen is by answering the question about how can AI support an RTM out of clinic, like expanding the clinic into the homes, improve our decisions, how we make our decisions while we are kind of like extending the care beyond the clinic and we are maintaining our patient-centered care. So that's a question for tonight. So in the traditional PT, when we have a visit, it's followed by a HEP at the end and then the next visit. So there is a big gap there. So we don't know what happens at home. But with the AI-enhanced RTM, we have the opportunity to follow up the visits with monitoring. And in the AI, when it does the monitoring, can give us some insight. And that is ended up like earlier intervention for us. So that means like before waiting for another visit, so we have the opportunity to monitor and take an action. So technically, the take-home message from my presentation would be the future of rehab is not simply collecting more data as the traditional way of RTM or physical therapy approach is kind of doing, but the future is collecting a lot of data and turn them into meaningful and actionable clinical decisions. So why initial like RTM matters? So that's a story about 10,000 minute gap that I created around it. So nowadays the rehab is extending beyond the clinic walls. And so that means that there's a need for objective monitoring. So I'm saying objective monitoring because some of subjective monitoring exists, but we need the objective monitoring of patient participation and also recovery. And so clinically, we visit our patients like 60 minutes a week, and but the patient spends more than 10,000 minutes outside the clinic, and we don't have any way to track them and get some like information about or like a to like a track their progress and their recovery. So RTM is providing therapists with the opportunities to evaluate multiple things. One is adherence, other is engagement, responses to the treatment, all in between the visits. And we can turn that objective, like a evaluation, objective measurements or metrics into an actionable insights. What AI is generally doing, so AI is excels at pattern recognition. What it means, like AI is able to detect the patterns, trends, relationships within the large database. So in rehab, AI can help us like identify the changes, like in the movement quality. If someone has a poor movement quality, consistency, or if someone has a good adherence, or if someone has a like a symptom behaviors is changing, like engagement is changing, or the progression is changing, or the recovery trajectories are changing. So those are like can be detected by AI. So I'm going to go through more examples. So someone may show up in the clinic and this like the patient may appear unchanged during the today's visit comparing to last visit, but AI by the remote monitoring, so it's telling you there is a decline in the exercise frequency of this patient. There is also increasing in the symptom reports, like there is a like changes in the range of motion, or there is a worsening of the movement quality. So quality of the movement is poor with more compensatory like movements. And so that means like AI is engaging here for providing us a pattern that this patient is following in between the visits. So the framework is very like kind of like solid here. So AI should support clinical reasoning. It's not replacing that. So that's the framework we're following. So, and the therapist is the one that is remaining responsible for interpreting all the information and making decisions. So we are reliable and we are holding our liability for that. But the AI is the thing that is supporting our clinical reasoning. But we need to learn how to run that clinical reasoning in the first place. And that is all like saying like because there might be sometimes a conflict between our findings versus the AI findings. And we are the liable one that decides which way to go. So learning objectives from tonight webinar. So one is describing AI-supported RTM workflows, distinguishing data collection from AI interpretation, identifying some clinically meaningful monitoring metrics, and also how to apply AI insights to progression decisions, and then also evaluate ethical and regulatory considerations. So let's go back to the topic about why initial like RTM matters. So I'm teaching at the school, and I know like not everyone believe in RTM these days. So remote therapy is kind of like not very much into the physical therapy programs yet, but it's growing. The reason is that because of the growing demand for the hybrid care. So healthcare industry is combining in-person and remote interactions. Started after the COVID time, but it's growing now because of the AI. And a lot of patients are now expecting some support beyond the clinic. So that's hybrid care. And so a clinical example of that is mainly like a post-op, like a following total knee arthroplasty. There's some recovery, but it's primarily at home because the patient is tied to the home and also the commuting is hard, and not every like pieces of the recovery can happen in the clinic. So the therapist should make a decision on like a brief clinical observations, but most of the rehab is occurring somewhere else. So that's the thing that happens. And then there's a need for the adherence and visibility of that adherence, but rather than just subjective information. So the AI is here to help us to make a better, uh, like a, make a better decisions around our patient, rather than self-reported type of like a engagement metrics and also adheres. So, and keeping like in mind that self-reported adherence exists right now, but it masks the reality. So there's some challenges around that. So, for example, the patients can remember effort more accurately than the performance quality. So a patient may come on to you and say like, "Oh yeah, the exercise is getting easier," but when you look at the AI enhanced like RTM, you see like the adherence of one patient is 92% versus the other one that is 37%. So they are different in like that makes a differences in our clinical decisions. So, but if we don't have that tools, AI enhanced tools, we don't know like the engagement of the patient. We don't know the quality of the movement, the adherence. We don't know a lot of other details that are objectively collected. And just by relying on the self-report of like the exercise is getting easier, we cannot make all of those conclusions and also decisions. So what is RTM? So RTM is uh, monitors the treatment's adherence and response outside the clinic. That is one part of it. So RTM extends observation beyond the scheduled appointments, so the therapists can gain some insights into how patients interact with the treatment plans in the real world environment. How we like we do that. Like clinical example would be a patient reports progress, and then but the RTM reveals there is a declining in the participation, there is a changes in the pain scores, there is a reduces in the exercise consistency and the quality of the movement, and now the therapist has a better picture of what is happening rather than only like instances in the clinic. The R team also used patient-generated health data. So data may include, for example, a plan of a care generated by AI about the symptoms report, like collectively about all of the symptoms reported like after each exercise, a feedback from the patient, or the range of motion measurements that does also can be included, and also progression in the range of motion, like a patient is able to go to higher range of motion that can feed into the AI generated health data, the plan of a care. Or like a participation is different, the quality of the movement is different. And those are can be all fit into the AI and provide a longitudinal view of the recovery. So if someone is coming to your clinic today and until it's getting easier, but you are looking at the other objective measurements collected throughout the week, so then you can better decide about what is happening. So rather than only a single variable, so you are able to monitor in between the visits. The other piece of that is tracking engagement of that. So for example, here you can see that like you're able to give a real-time feedback to your patient. That improves their movement quality. The also AI is able to analyze the quality of a movement like over different like exercises and send you the outcome. It could be like between like a gait assessment, it could be like a posted some type of like a balance assessment, it could be range of motion assessment, and also analyze the quality of the movement. So then the AI is able to collect all of those inputs and help for, like generate a plan that is helping us to make the next decision. So technically, like two patients may demonstrate the identical adherence rate, So we're not, we should, I mean, based on a self-reported kind of like a video checking and also sending videos, they might be the same. But when you are looking at the quality of the movement, range of motion, gait assessments by the use of AI, you see, or the feedback collected, or the quality of the movement, you could see like there are so many differences. The RTM is also support the continuity of care. Back to the example about the total knee replacement. So the recovery becomes a continuous process rather than a series of isolated appointments. So you can like given access to like extra scheduling or extra like type of a sessions through the AI, through like an offline type of like a continuous care, and that is like a kind of like a helping you to enhance the recovery. So more about the traditional RTM workflow. So typically people send video interface to the patients or printed version of the exercises and then collect some subjectively reported patient activity. So that's very much of like a how many times the patient logged in or like a which exercise was subjectively reported to be done, and also collecting some like a pain and also difficulty level. So it's not going through a lot of like a movement quality and also assessments through the AI, and also not also like looking at the trend and the pattern of the recovery. So and then there's a like a huge amount of data because like a physical therapist should sit down, watch the videos, and that means that a lot of time. So the clinicians should are not able to review the reports periodically. So they have to do it like they can do it like a not repeatedly. And so the problem can may initiate long time before they started. So the AI is then over there like looking at the movement quality and then can do the early identification versus watching the videos or like a traditional RTM workflow. So, so the therapist is able to discover that before the next visit, and then there is an opportunity again for earlier intervention. But that's not possible when we send the videos and do some subjective collection of the data. But keep in mind, like the more information, like what we do in the traditional RTM by the videos, is not automatically improve the decision making. It's a huge data set that we collect, but we're not able to make a decision around it because that's a huge data set, and we don't have a tool to analyze and assess it. So it's difficult to review. That's one thing. That's one limitation of the traditional RTM, and there might be like hundreds of the exercise sessions, and they may generate like thousands of data points, but the human review is very limited. So the monitoring is limited to some maybe data points about the logging information or maybe the participation that are subjectively reported, and that again delayed the identification of the problems. So that is like the problem with the limitation of the traditional RTM. And so the patient may get a decline slowly over 2 weeks in the recovery. And we don't know why, because based on the like a participation in the clinical visits, that patient is supposed to show progression, but actually the decline is already started because the patient is already disengaged and was not monitored in between the visits properly. So what AI tools add to the RTM? So one is recognizing the adherence and recovery pattern. So therapists are able to look at the movement quality. They can analyze like hundreds of like exercise sessions. So if there are like 10 trials, 12 trials of one exercise, they all can be analyzed. If there is like 5 days a week of doing the exercises and there are five exercises, so there are 25 technically type of like a recording that should be reviewed if it's a video, and then if there are 10 trials each of them, so that means like a therapist should be like a review 250 trials, but actually they'll all be done by AI. So AI is able to look at the quality of the movement, the adherence to the movement. So sometimes the patient is doing a poor quality, sometimes they are doing like a good quality. So the feedback level does matter. So the AI is able to detect the trends over time and look at the trajectory rather than the isolated measurements. And then they can identify the risk of disengagement, and that ends up to the generate personalized feedback. So personalized like a progress note or personalized type of like a personalized type of trajectories or like a graphical reports that show the adherence and also the improvement and the recovery. So in more details, so if I want to give you an example, so for recognizing the adherence and recovery pattern. So example is a patient is recovering, for example, from total knee arthroplasty. And then the patient is showing a gradual decrease in the exercise frequency over 2 weeks. But the patient is reporting everything is going well. So, but there is something that is not working here. And AI is here to identify the trend. So there might be like a lack of participation, there might be some pain level, there might be some difficulty, there might be some limitation or like a restriction in the range of motion. So that is like a trend that can be detected by AI. The other thing is rehabilitation outcomes can be influenced by the trajectories. So, for example, there's a knee flexion improved from 90 to 110 degrees during the first 2 weeks. But then it's plateaued around 112 over the next week. So the patient is not progressing. So it's still like the progress appears positive, obviously, but AI is able to identify there is a plateau there, and that requires a reassessment of the treatment and also may change to the intensity or the exercise selection. So that is what AI can tell us, like a changing into the exercise selection, like maybe like a changing in the plan of a care, generate a new plan of a care, and like a change the difficulty of the exercise, intensity of the exercises. The other positive part of AI is identifies the risk of disengagement. So sometimes there is a reduced participation and before the treatment failure or dropout. So for example, a patient continues logging into the system, but the session duration is decreasing and repetition declines and exercise completion becomes inconsistent. So that's alarming, but we didn't know that without the use of AI. So AI is telling us this patient may have it like an issue with the intensity of the exercises or may have an issue with the number of sets and repetition. And that's the behavior, and the behavior is inconsistent. So identify some behavioral pattern change, and that can be associated with the non-compliance. So before a therapist can kind of like recognize it. More about like a generate personalized feedback. So I showed a video of that. Like AI is able to give an audio feedback, is able to give a visual feedback about the correct form of standing in front of a camera, best quality of performing one exercise. So that immediate and real-time feedback can be very like engaging for the patient. And also a feedback that can be collected after each exercise can feed into the AI. And so then before the next visit, there can be like some suggestions from AI in the change of intensity of the exercises, in the change of like a repetition or like a improving like the plan of a care before coming to the next visit. So those are all what AI adds. But the thing is, how we as physical therapists can use that tool. So that's something that we need to learn about clinical reasoning. Keep in mind the AI, we behave AI as like it's generating hypothesis for us. So AI should be viewed as a source of clinical clues, and we make a hypothesis around it. When you look at that generated plan of a care, even if it's based on ton of objective data collected through the RTM, but it's still sitting at the level of hypothesis. So the goal is learning like us, like we should learn as a physical therapist that AI is not telling therapists what to do, but to highlight the pattern and let us know like more about the patient. So that's how AI is doing. So we behave every recommendation from AI as a hypothesis. So, for example, when AI identifies declining in the walking speed, reducing exercise participation, lower quality of the movement, changes in the pattern of the pain, the possible explanation from the AI perspective could be like a worsening of the condition or like a fear of avoidance or like exercise intolerance, recommendation for the changing in the intensity or like psychosocial barriers or some like health changes based on the feedback collected after each exercise based on the performance. But AI found the signal. AI is not determining what is best for the patient. That's a thing that we need to learn. So again, about the clinical reasoning, AI informs the progression or like a regression decisions. Give us some recommendation. So for example, and progression like a for example, from the AI perspective, that tells us like it should be based on the progression. So traditionally, like we decide like oh, this is 2 weeks, we see some progression, so let's progress to higher intensity and more difficulty. But AI is like we do a clinical reasoning based on the AI objective information regarding the readiness for advancements. So that's the point that we are doing our clinical reasoning or enhance our clinical reasoning with the AI insights. So compare it with the situation that AI supported decision would be based on or the advancement of the plan of care would be based on if the adherence was stable, if the engagement was good, if the quality of the movement was progressing, if the trend of symptoms like a pain and difficulty is declining, if the range of motion is increasing, if the consistency is getting better. But now we can do a clinical reasoning and say, okay, now progressions is becomes evidence informed. So again, like AI augments but not replaces our clinical judgment. So AI can modify the patterns, but we're the one who are collecting and then get some insight from the AI, like whatever is about the quality of movement or all of those information about the metrics. And then we are fully appreciate the patient values, goals, or the context and do our clinical reasoning. So AI may recommend progression, but the patient reports, for example, fear of re-injury or low confidence. So that's us who is deciding about the clinical reasoning and maybe like there is a flaring of some symptoms. So we are delaying that progression based upon that, even if based on all objective assessments and collection of the remote therapy, there is a recovery and also progression based on AI, but including all those like a patient goals and values, we decide to like delay the progression. So what is the clinical reasoning model? So from the input to action. One is the input. So we do monitoring of data and patient reports by the AI. So clinical reasoning begins with information gathering. So RTM expands the quantity and quality of available information. Now, rather than only like clinical resources that we have in the clinic, we are expanded over the whole environment of the patient. And those sources may include movement quality, range of motion progression, changes in the trends of pain and difficulty, changes in the behavioral of the patient, quality of the movement, or like engagement of the patient, adherence to the exercises, or some key insights about also like about the feedback collected after each exercise and adjusting them to the goals of the patient. The second step is interpretation. So we can benefit from AI assisted pattern recognition at this stage. So AI is organizing all of that information, identify some meaningful trends. So you can see like a trend in the range of motion progression. You can see like a decline in the pain and difficulty for each exercise or after each exercise. You can like it can like go over the feedback collected after each exercise. Example is that like there might be like a declining in the scut quality, or the quality is like for example, I mean by quality is like the patient was doing some compensatory movement, so to make the scut easier, like leaning forward, for example, or detecting trends in the exercise frequency, performing of that. So that interpretation can be passed to the AI, and AI can assist us in pattern recognition and give us some insights. But now is the third step, that is decision. So clinician is here, is our role right now. Evaluate all of these findings. So there might be multiple explanations existing for the same data pattern. And the therapist is the one that integrate all these objective information, data, examination findings. So we can simply pass some assessments through the like a movement assessment or like a functional assessment, like a gait assessment, balance assessment, and then do like a leave it to the AI to do it at home by the patient. So look at all of those evaluations, and there might be some explanation. So example of that, like there are some declining in the exercise participation, could be due to the pain. So we are kind of looking at each like a pattern as a hypothesis. Is there any change in the pattern of the pain? Was that like a because of the limitation in scheduling more exercises? Is that psychosocial or a psychomotor or like a fear of like avoidance or like some even like a misunderstanding of the instructions, or like each of them requires some review. So we are the decision maker, we are the clinicians who are gaining all of these insights and then explaining. And then the next step is action and reassessment guide care. So every intervention that we add so becomes a new clinical hypothesis. So we have the opportunity to continue the reassessment. Example of that, for example, if we reduce the exercise dosage, now the question is that does that improve the movement quality? Does that like change the trend or the pattern of the progression over like home exercises for the patient? So everything in the reassessment is now new hypothesis. Now we are asking AI to check all those hypotheses and then give us a new trend in the in like outputs. So now let's look at the key metrics for the AI. So what we can measure with AI, I'm sure like I'm not going through all of the metrics, but those are the best that available for everyone nowadays so that you can look at it. But I'm sure like in the next year, you can have an access to many more, especially like at the level of like organizational or like a bulk of patients that could be different, but this is technically focused on one patient. One is exercise adherence and dosage. So adherence is not only limited on checking the subjectively telling like I did the exercise. Adherence includes the frequency of doing one exercise, duration of doing that, consistency, like if there is a poor performance or better performance, completion of all the prescribed movement, like he completed all of the sets and reps. So that's the adherence. Adherence is not only limited to subjective report. So understanding and also the dosage is very essential for that treatment response. So that can be one metric for the AI. So AI is able to look at the number of repetitions, duration, movement quality, consistency, completion, and give us a report and insight around that. Like example of that, one patient did 5 days a week, another patient did 2 days a week. So we're expecting different outcomes from these two patients, and they're all kind of like a part of a category of the adherence. So another key metric is movement quality and biomechanics. So you can look at each exercise and then analyze what is happening there. So in each exercise. So movement quality is very important because it helps like it tells about the motor learning also. It tells also like how the exercise was performed. Like if the patient performs every Scott, but for example, there was a like a valgus collapse, for example, or the weight shifting was not good. That reflects actually like from a perspective of motion analysis in the range of motion. And whoever is doing the motion analysis is able to convert all these like differences in the form, normal form versus like, for example, different forms of doing the exercise into numbers and then reflect it as a like a trend to us. Or for example, in the SCOT, there is a trunk compensation that was increased. So that is like a saying the exercise was completed, but it was not effective. So that's what AI is telling us by doing some motion analysis. The other metric for the AI is consistency across sessions. So that reflects very much the movement control and also motor learning. And that variability is like able, like is telling like if there is a skill acquisition happen or not. For example, one day there is an excellent performance in one exercise, but there is a poor performance in another day, and there is another excellent performance in another day. So that means like there's not a stable performance across days, and that is not a good like a consistent pattern. So there might be some like a need for explaining the instruction or explaining the exercise to the patient. Another metric is detecting compensation and asymmetrics. As I told, like there when there is a like a correct form of doing one exercise, so those compensations can be measured through like a range of motion, like a gait, like a stride, or uh, like all of those like measurements for the gait and balance, for example. But if there is a asymmetry or deviation or some compensations, that can be all reflected and can be measured by the motion analysis by the AI system, example of that, and then reflected as a movement quality analysis. So for example, post total knee arthroplasty patient, for example, demonstrates like some increasing trunk leaning. So that reflects in the range of motion. Unloading some surgical limb, that reflects in the some gait measurements. Some like a range of motion appears improved, but technically these two can worsens the movement quality. And that can be reported by the AI. And we can look at that and then detect those and then work on those. The other thing, key metrics are simply range of motion progression that can be measured. So range of motion trends, that's a very unique kind of like objective insights into the recovery, and rate of improvement can be like a part of like a total improvement, like shoulder flexion. It can be 90 degrees, week 220 degrees, 123 degrees. So that improvement can be continued. And keep in mind again, the AI is able to do real-time feedback, and that can enhance the engagement and also improve the range of motion very much, because that tells like if the arm is actually, for example, in this case in the shoulder flexion, was like a doing enough flexion or not, and that's very valuable. Pain response and symptom trends, so monitoring all of the pain responses. So there might be some pain responses after one exercise, but it's different than the other exercise. That tells like if there is a treatment tolerance to one exercise comparing to the other. And that provides some early warning signs. So some exercises that are difficult may raise more pain. Some that are not that difficult can be different. And the result is differences in the participation or increases in the participation. And that supports the progression. That trend can be tracked by the AI. So also like a biomechanical changes longitudinally, like the trend over different weeks or for a long time, like a multi-week improvement. And that if we have some patients that are returning frequently, so you can always have a multi-week, some months, or even a year of a data and look at the trend of their improvement or the behavior. Sometimes it's improving, there might be like a seasonal effect, they're active in one season, but they're less active in the other season. So that is like a seasonal effect in the trend, and that can be suggested by AI. So objective data, technically, it's reducing the uncertainty around the progression. So we don't have it only relying on the a visit, like a clinical visit data, but we have a continuum of the data. So now the question is that would you progress based on one good session or 3 weeks of positive trends? So that's the difference that we can address with the use of AI. Again, also adherence can be beyond the completion. Again, it's technically about the quality, frequency, and completion of one movement. Like subjective report is not enough, but also looking at the quality would be very effective. And AI can identify all of those behavioral patterns, engagement tracking, and also frequency, and also the quality, all of those that can indicate and help us to do clinical reasoning. So to summarize the common AI outputs, one is adherence summaries. So that is like a frequency, duration, movement quality, consistency of the movement. So that can be concluded into a 85% adherence. That's a good metric, but that's concluded out of all of those. And then also the AI is giving us some a risk alerts. Like if someone is uh, at the a risk of disengagement. So based on the behavior or the trend of behavior, for example, there is a trend of increasing in the pain, or there is a trend in the improving the range of motion, or a disengagement into kind of a frequency of the exercises that can be automatically identified by the AI. Progress report. So everyone knows these days how AI is helping us in the a documentation. AI can also output some of all of those adherence, movement quality, and also the trends and also the behaviors into some write-ups for us. And then we can report them and it can summarize all of those the writings. It can do also a summary of the exercise performance analytics, which is like a movement quality and objective trends, like a range of motion. Another example, again, like a post-operative knee. For example, you can see a patient about how you're going to do the clinical reasoning around that. So adherence remained high, but you see the range of motion is plateau. So that means compliance, doing all the sessions does not guarantee the improvement. So that is what it tells. Look, and then you can look at the outcomes additional to the adherence, because that's telling you that patient is doing all the exercises with good frequency, good amount of a duration, but something is missing here. Maybe I should look at the outcomes, movement quality measurements. So the patient, for example, completed all of the 90% of the prescribed exercise, but the range of motion is unchanged. Now the question is the why. So the next step is going deeper by the AI capabilities. And that means a frequency remains stable, but the patient declined in the exercise effort. That means there was a poor performance, poor movement quality, more compensations, or more lack of a form or good form or correct form of doing the exercises during the performance. So, for example, the observation is the patient shortened the duration of the repetitions or the range of motion, for example, for the shoulder flexion or for the total knee, for example, didn't reach that level of the Scott that was required, or only reached a threshold, but not moving beyond that. So exercise is completed, but the dosage should be changed at this stage to improve the range of motion. And that's our role. So based on all of that, outcomes and also information from the AI, the therapist is now adjusting the progression strategy. And that's our clinical reasoning. That's the piece that we do and build up all of these, based on all these information, based on all these objective findings. So we do increased coaching, modified dosage, higher dosage, and also updated the progression criteria. Maybe replace one exercise or two exercises with more difficult one. And then run another round of AI. So we do objective monitoring. So it supported our earlier intervention because before knowing that after our a fourth visit, now by the use of AI, you're able to detect it earlier and then take an action of that. And then you can see improvement in the range of motion by changing your clinical decisions, by enhancing your clinical reasoning and identify the problem earlier and then take an action. Another example of how we can do the clinical reasoning with the use of AI is in the low back pain. So for this case, for example, the symptoms and activity patterns revealed, symptoms fluctuated but tracked remotely in between the visits. And so the RTM shows some changes, like a pain increased during the weekends and activity decreased during the weekdays. So that pattern emerged by the AI. So, but that would be remain hidden if we only rely on the visits. So what we see is the activity trends based on AI. So because it's collecting all of the information, objective information from the exercises, it's now correlated with the pain reports. So we can find there is a relationship between the symptoms, that are pain symptoms, and the behavior, which is a lower effort and movement quality in between the visits in the weekdays. And so we can better understand the contributing factors. Now the question is that, did the pain reduce the activity? If so, I should work through my clinical reasoning on some plan of care that reduces the pain level. So that means that there's an earlier detection of the engagement, and that detected the reduced participation by looking at a relationship between the symptoms behavior and the activity behavior. And so we may, for example, for controlling pain, it reduces the session frequencies for another a 10 consecutive days. Or the therapist can contact the patient and ask about what happens that you got at that level of pain. So that means that timing can be a matter, and we detect the disengagement, also the changes in the pain level, and do earlier clinical decisions and also taking an action. So now the question is that when AI can be wrong. So one is it's the same as all of the algorithms. AI also performance depends on the input quality. So the principle is for any analysis, if garbage in, garbage out. So if there is an inaccurate data, produces inaccurate recommendations. If a patient is giving wrong feedbacks to the AI, same as us, AI is our assistant. So if it's hearing wrong recommendations or feedbacks, So it's analyzing in the wrong direction. That's all, like a wrong pain report or wrong, for example, the performance report, or a lot of like a kind of like a reflections that does not actually like write about the patient. The other piece that can be wrong is missing context can mislead the recommendation. So what it means, AI cannot fully appreciate all of the life circumstances. What it means, like there are so many life like events or information that can remain invisible. For example, some of the disengagement may not be the result of the treatment failure. It could be because of some emotional events in the life. So that means there is a missing context here. The other piece is all of these AI algorithms, they have some biases, and that remains possible. So when they are like AI is generating the progress note, it can like forget, or it can it can be biases toward more like a positive like a outputs out of the uh, out of all of the outputs. So to put it into like a note that can be used for the reimbursement, for the AI, for the insurance reimbursement. So that is all depend on the biases and also the training, and that can influence the recommendations. But it's again like our clinical responsibility to look at, for example, the drafted progress note and evaluate them critically. So that's all of our responsibility because the biases can be there. So that means a human in the loop model. So AI analyzes, clinician interprets, and the patient is setting the goals and values. So, for example, again, like a clinical example is there's a 3 weeks of adherence, more than 500 exercises repetitions. There's a range of motion trends reported by AI. There's a trend of symptom fluctuations like a pain and difficulty. And then the therapist, based on all of that, and then that concludes by the AI with some insights and recommendations to us. The therapist now is determines whether these findings are clinically relevant. Like if, for example, on that previous example, if there is a relationship between the pain trend and also the quality of a movement trend in the weekend and the weekdays. So now here the AI identifies, for example, declining exercise participation and recommend us, give us an insights that it could be because of the worsening pain pattern. It could be because of the fear reported after the exercises in the feedback. It could be because of the patient has some scheduling barrier as reported after each exercise or some family obligations. So we are combining and then looking at all these trends. But the patient is the one that who guides and is the central source of the values. So example is that, for example, among all of those progression and positive things that we are getting from patient, so the patient is say, I'm not feeling confident yet about one more, for example, one more difficult exercise. And so they might not be interested in doing more like a progression into more difficult. So again, like the human in the loop model, that's us that are interpreting, and the effective rehabilitation combines all of those objective data and including our expertise and also with the patient goals. And that is the kind of like what we're how we're doing the clinical reasoning. Not AI is doing that. So what I did for another side of this story about the clinical reasoning is the educational side of it. So one project that I was conducting at the Samuel Merritt was through the simulation-based AI education. Why simulation? Because the most of the PT right now at Samuel Merritt learn some level of clinical reasoning through the patient encounters. So we had a simulated patient, and we asked them. We asked, I mean, the students engaged into 2 rounds of the simulation, And that is all about enhancing the AI literacy about the health. And that was through the simulation-based AI education. So rather than only lectures about technology and telling them just a broad level of information like tonight, so the students engage into some like hands-on experiences with the simulated patient. So that was also a safe environment for exploring the strengths and also the limitations of AI-supported decision making. So what happened in our simulation was, first of all, because AI can collect a lot of data, but that doesn't mean a better decision. That was something that we were passing to the students. So the example scenario that they did was they managed one simulated patient that has a commuting issues, and then they were supposed to prescribe a HEP for one session and concluded that plan of care home exercise plan through all of the initial evaluation and also some biomechanical metrics and also symptom reports. So, and also the AI generated plan of care. So students were supposed to better change the plan of care in an appropriate way based on provided AI generated plan of care, based on the initial reports and also evaluation of the patient, based on the movement quality measured has been done with the AI with and shared with the students, and also some symptom reports based on the one session of the rehabilitation in the clinic. And then they have to modify the plan of care, and also they have to look at whether it's appropriate to do some progression and also manage some also education about the use of technology at home with the patient. So they were supposed to encounter with the SP in a way that they are able to train the SP to use the technology independently at home. So the educational goal was not about if the students can use AI. Everyone these days can use AI, but it was critical thinking in the first place. The other thing is in enhancing their AI literacy to the level that they can cover up their patient as well in the encounter and hands-on experience. So the students use AI-supported monitoring dashboards. So they review the simulated patient cases, including some symptom trends, movement quality, AI-generated summaries out of the initial evaluation and also the first session. And so the students reviewed the case scenario and the performance data and discovered that there is a like a there is a poor movement quality and also a persistent pain. So they had to modify the plan of care. So they did some clinical reasoning in the simulation session, and then they practiced if there should be a progression or the regression decision, or a substitution of the some of the generated plan of care pieces, exercises with some new exercises. So key educational message was the future therapist does not need to build AI, but they need to think critically about the AI and also how to pass it and educate their simulated patient in the encounter. So what happened as the outcomes of the simulation? The students reported higher confidence in interpreting the monitoring data, so they were more comfortable in doing that. They reported improved ability to discuss the AI strengths and limitation, mainly in reporting the objective data. They had a better integration confidence on integrating the objective data into their decision making, like how looking at some of the reports would help them to decide about the plan of care. And also they said the learners, all of the students recognize that all of the AI recommendations require some human verification. and human judgment is the most important part of it. So key findings was AI literacy increased the appreciation for the clinical reasoning, but not dependence on the technology. The other study that I was running in the class that I had was teaching AI through some projects. Why the project-based learning? So team working, because rather than they encounter like clinical problems, patient needs, and also the workflow changes like in a group of people. So in a collaborative problem solving groups in a team. So they can work together and then decide about and also do the clinical reasoning together. So that was the approach I did. So there were some teams of students. So students worked together. They worked with one of their students in the group mock the patient, but they actually had a realistic patient monitoring information. So they identified the trends and also potential clinical concerns, and also the students experienced some complexity of interpreting some real world data. So in the next session, they had to evaluate the AI generated recommendations and modify the plan of care. So they substituted some of the AI recommended exercises with some difficult exercises and look at the trends and also the cautions. They developed plan of care. So, and also they monitored the mock patient over 4 weeks by the objective data and also looking at the adherence and also adherence data and also the feedback data. And then in the last part of the project, they had to do a discharge plan and also defend their decisions using their clinical reasoning. So they had to justify their decisions using the evidence and also the patient context at the end. So the strongest teams did not simply like identify data technically. They look at the trends of the data. They had to support the data. They had to put it in the report, and then they had to justify it based on their clinical reasoning. In IM, so they had to submit 4 assignments according to that. So the AI education is technically most effective. So the lesson one is when it is clinically grounded. So it's more effective when it's like a practice with the like a mock patient or patient engagement or management or looking at the trends, looking at the all of the data and also going through the interpretation versus hearing a lecture about the AI. So students learn better if the AI was embedded into like a projects, and also they had to do some uh, engagement. They had to be engaged into clinical problems. The lesson two was collecting data is not enough for understanding the cases. So sometimes we're collecting a lot of data, we're thinking like a more information leads to better decision, but technically AI is collecting a lot of data, but we are the one that are doing the clinical application. So we are the one who is taking the principles of the clinical decision and going through all of those data. The third one was the students, they need to learn to verify AI outputs. So some students had an issue with reading the objective data, so range of motion assessments. So even looking at the trends, if it's like a declining or if it's like progressing. So also reading some objective data that needs a training, that needs a verification as a part of like education, and also making the students to think about if they are putting together all those pieces of objective information, is the recommendation by AI is reasonable, and what evidence you have from the AI pieces. So that's also one other lesson that we learned. So that skill is missing in the educational setting. That was the one that I was working and developed. So So technically, like when we are evaluating AI outputs, there are four critical questions when you do a clinical reading. One is the recommendation clinically relevant? Can you verify it by the pain trend, by the adherence trend, by the duration, frequency, movement quality, by the range of motion, by the assessments, by the consistency, for example, all of those. Is the recommendation clinically relevant? Is the rationale or the evidence are understandable? Again, like we're not expecting these days like every PT would be able, a skill that is developing in the educational setting to learn about how to do clinical reasoning out of all these data. But the second question if is the rationale understandable? Are the evidence are matching with the recommendation? The other piece, the other question that we should do when we are doing our clinical reasoning is, does it fit the patient context? So there are some individual circumstances, and that is a patient context, like a living environment, caregivers, psychosocial factors that are involving. So does that recommendation fit into the patient context? Like we are working with the geriatrics group, for example, and there is a high or like a fear of like a losing a balance. If the AI is showing like a better balance performance, so is it fit into the and recommending the progression in the balance difficulty? Is it fit to the patient context, like a living environment, for example? The last one is the all of the time ask about the evidence that support our decision. Are the AI recommendations should align with the clinical evidence when they are possible? So that is like if those recommendations are evidence-based practice, if you can support them by the similar studies and also the evidence-based practices. And that's remaining the foundation. So ethical considerations. One is when we do a use AI, one thing is about patient autonomy. So that means like patients also need some education. And during my project about educating the students about using it in a simulation based scenario, we learn like a patient, even the simulated patient that has been through a lot of simulation studies, they needed some autonomy and also education about the use of AI. And that is the like a very much essential. And that is like a very much contribute to our decision making because if the patient is not able to follow the instruction, if the patient is not able to use a technology independently, so that's an issue. That's something that all of these AI tools is there, but it's not applicable because there's not autonomy. It's not preserved. The independent, like a patient is not able to understand how AI is contributing to the care. So that's something that should be worked very much. The other thing is transparency. A lot of patients have concern about their privacy and the influence of the technology around their life. I mean, I do have it. Everyone does have it. And then think about the camera on your system opens up, tracking your motion, and you don't know if it's capture anything from your private place or not. So that transparency from even like the system and also from the clinicians help very much. It should be reassuring like these days AI, they don't record any video. They're not capturing any of your images. And that's at the ethical level and the considerations. So that is another kind of considerations that promotes the acceptance and the ethical use. And then that is also technically can be part of our clinical reasoning. Sometimes a patient would complain about it, and even if they are engaging well, they're also having showing good adherence and progression. That is a psychosocial concern about the ethical use of AI. And because of the lack of a transparency, that is making a concern and they disengage. So that should be addressed. The other ethical consideration is the accountability of the clinician. So over relying on AI, it happens over years, especially like with the new learners in schools that they can mediate a lot of their projects and also works by the use of AI. They learn to go into things faster. That can damage their accountability as the clinician. So that is part of the ethical considerations that we are holding the responsibility for the patient outcome, and that remains unchanged. That's another concern that everyone noted. So AI is not able to be as a professional and accountable. So we're the one who signs the notes, we're the one who owns the decision. The other ethical consideration is AI is also under a lot of development, and there are a lot of biases. And I mean, it's always like the human learning that we learn more and more and more complex. And we are different than our previous generation, and our previous generation was different than the other generation. The algorithms are also the same. So they can have some biases, and that reflects also to some extent also the data that has been used for training them. So that's also very important, and that may influence the recommendations. That's something is over relying on the AI is not possible, and the all of the recommendations should be evaluated for the fairness and appropriateness. Even if AI is able to objectively measure like 500 repetitions of the exercise of the patient, gaining some insights, and then also extract some parameters for us, but all of them are under some training and also some biases because of the data set that was initially provided for them. There are also some regulatory considerations, and that's good when you're picking up your RTM, AI-powered RTM device or the platform. One of them is the HIPAA and privacy requirements. So patient data, be sure like they are remaining protected, and there are some security protocols uh, for the platform because the AI can go now extend beyond the clinics into the private area of the patient. And they might not be aware of that, but you know that the there should be some HIPAA and also some privacy requirements for all of the AI system. The other consideration is the documentation standards. We teach at school here what is the best documentation style and the clinical rationale. So that should be also considered when you're looking at some of the device if the documentation is rational based on these standards. And if it's drafted by the AI, that should not replace our professional reasoning. And keep in mind, again, there are some biases, and that's reflecting the training data set around that. The other piece is about the regulation, the RTM reimbursement considerations. So everyone knows in 2026, Medicare released new CPT codes, and that is helping the hybrid care, extending the care with the use of AI, and you can get reimbursement, you can get another revenue, like line of a revenue, and when you're picking up the system that you want to monitor the activities, that should be reflected and demonstrate some clinical value. So that means some documentation should support the compliance and also supporting that new CPT codes and also the monitoring time. There's always some policies from some organizations that should be also be um, respected technically. There are some AI guidelines, and also like there's some like a safety policies in some organizations. So when you're picking up some like a systems AI like a powered HEP, for example, an RTM, so that organizational governance policies also like should be considered. All right, so again, like about the clinical reasoning, we need to identify high value use cases. For example, we want to implement it in our clinic. So how can we do it? So that implementation first is started by the solving some meaningful clinical problems. So you want to implement it, you want to have the AI supported HIP RTM in your clinic. Um, so, but some of your clinicians are struggling with that, and you understand it, and you want to work on that. So, how we can implement it, how we can even like implement it in the clinic, and we learn about it. So, for example, you want to know like how to implement it for the total knee arthroplasty. This is very like a post-op clinical case, like monitor the range of motion progression, so, or detecting some functional plateaus because you're curious, like why the range of motion is not increasing after 2 weeks. Or you want to monitor the exercise participation, or your ortho surgeon is requesting for the monitoring of the exercise participation and also the adherence. Or, for example, you have a high value case that is like a low back pain. You want to check on the symptom fluctuations. If the pain is fluctuating or the trend of a pain is different after some exercises versus the other, and you want to replace and change that. If the activity tolerance is different, or if there is a like early disengagement, and you can look at the trend of the objective data. The other high value use cases are the balance and fall prevention. So you want to monitor for the balance cases the exercise completion or the gait like improvement. So you want to track the consistency of the gait over time, or like if there is a long-term adherence. For example, you have a patient, like I worked with the diabetes patient for a long time, and you want to make sure there is a consistency in their like workouts or like exercises, and you want to make sure like there is a long-term adherence. So then that's going to reflect in the balance prevention. So that's the question for the implementation. So the first step is the piloting with some defined outcomes, like start with some small and measure some meaningful outcomes. Like if you are like doing at the organization level, maybe doing it at the whole level would be really hard. Some like clinics start with only one clinician. Some clinics ask all of the clinicians to take care of like their patients. Sometimes they ask a clinician from like outside, like those working with the RTM companies to take care of their patients for the RTM. But these are all relevant, like based on the clinics that you're managing. But initially, like a piloted with small and defined outcomes. For example, focus on some functional improvement or pain reduction or range of motion gains rather than going comprehensively with the AI to everywhere, or looking at some adherence like a frequency or like a duration, engagement, and also like a retention, or some operational outcomes like if the like there is a like a patient satisfaction, or if you can see like a connection between a patient satisfaction, program completion rates, and also some behavioral outcomes. But it start with a small subset of the outcomes that you want to follow, and then look at that like if the patient did the patient care improve based on those small and pilot outcomes? Did the technology work? If, for example, for you is engaging a patient independently into AI, like a monitored exercise, and make sure you have the range of motion at the end. So only focus on the range of motion gain and then see if that's helping your patient. So the real-time feedback your patient is getting through the range of motion, that helps your patient very much. So start small, and also clear measures. The other piece is for the start for implementing is training the clinicians. I mean, a lot of owners are interested in doing that, but there's a lot of struggles from the clinician sides. And technology lectures, they're not sufficient by itself. So maybe like explaining and training, ask for more training or like engaging in some training about some AI generating information, mainly about like a range of motion, adherence. Those would be very helpful for detecting the patterns in your clinic and also making sure that the patient is able to stick to the recovery and also to the plan of the care. So, for example, rather than like teaching the therapist about how to use the dashboard, so teaching the therapist about like how to use the dashboard. This is the main thing. Instead of like starting by very complex question about if the dashboard is making sense for you, or the parameters are working with you, making sure like each part of the dashboard is like a useful for the clinician and they can look at the dashboard, have a subset of like a 4 or 5 out of all of those outputs, and then they can track the patient, they can like see who needs most of the like attention from the clinician, and then working on their engagement. Then also measure and scale like with the evidence. So when a clinician like learn enough about the use of a tool, using the tool, or when you are able to working on subset of outcomes, adopting them for your monitoring, now it's a time that you can do a continuous evaluation, expanded and then supported with some evidence that the R team is working in your space, in your clinic. All right, so the next topic is about the future of AI-enabled RTM. So where AI-enabled RTM is going. One is in our clinical reasoning, there are going to be more opportunities to have predictive analytics for the risk detection. Nowadays, the AI models are not very great in, for example, like or detecting patients that need most of the attention. They're still struggling there. But in the future, they're able to do early detection, identify the problems, and they're becoming more able in predictive analytics for the risk detection. So example of that, like declining the motivation or reducing this engagement or the risk for the balance or or falling or for the dropouts. So that's something that the AI enabled RTMs are going. The other thing is personalized rehabilitation pathways. So AI, after collecting all of those objective outputs by the monitoring, so it's also able to do some recommendation. So in the future, it's going to be more personalized in the pathway. So it's going to be more reliable. So for example, two patients may do a follow-up following like identical surgical procedure, but the adherence, movement quality, symptoms, recovery trajectories would be different. And AI is able to personalize the plan of care to their needs and give you better recommendations. Again, the personalization still requires therapist oversight. So, but it's in the adaptive pathway to give a better recommendation. The other thing is continuous monitoring ecosystems. Whatever we have today, that can be optimized in the future. So it's like expanding it. Therapists may have more access, like become more interested in doing like a monitoring ecosystem, so they are able to better like tracking the adherence, movement quality, risk predictions, and that clinical reasoning around that is much more important in the future because we automatically have an access to more data and we have more capacity. So the other piece is better integration into the clinical workflows. Right now, there's some RTMs that are good for the workflow, but in terms of uh, like objective data, they are lagging, they're struggling. So more of these AI tools are going to be embedded into, for example, documentation systems, EHR systems, and also RTM platforms. So AI is developing more and more and becoming more routine in the near future. And once the AI literacy also become more and more in clinicians, that clinical reasoning, learning about the objective measurements is also become easier. So, four core principles and key takeaways. The first one is AI can enhances the clinical reasoning when used appropriately. So, keep in mind that AI is able to look at a lot of measurements in between our visits and identify the patterns. That includes movement, that includes the symptom behavior, that includes the adherence, but that might be difficult to recognize manually. So that's what AI do for us. So that improves a visibility in our patient performance in between the visits. So that's the first key message. So AI is helping the therapist to see more from the patient. But that doesn't mean that they are thinking less. So some people, when we do our documentation, we're feeling like, oh, this is great because we're not doing the documentation that much anymore, which is great actually. We're not like a writer, we're a therapist. But in terms of a clinical reasoning side, that doesn't mean it's going to be a simpler word. So AI is doing our job. No, this is not right. AI helps us to see more from the patient and then decide better. The second core principle or takeaway is the RTM data requires meaningful interpretation. So that means we need to learn about how to look at all of those objective measurements, all of those trends. And even if we have an access to the AI recommendation, insights, but we are also responsible for meaningful interpretation. A clinical example would be when you're looking at the dashboard of a patient and it's not changing in the in terms of recovery, so the patient recovery is not changing, so we are the one that out of all of those trends decide if we are going to do something that can change the recovery, if we are going to change the dosage or intensity of one exercise or replace it with something else, or focusing more on the education or maybe psychosocial or psychological perspective. So that is the meaningful interpretation that AI is assisting, AI recommendation insights would be helpful, but meaningful interpretation is is our job. The other takeaway is we need education. Both therapists and also the patients, they need education about the AI literacy. Even the new generation, they have a better AI kind of a literacy in looking at the generated information. But both clinicians and students and also the patients, they need to get some education about using the tool. And that is also connected to your work. Like if you're overburdened with a lot of patients, but we want to make a better decision, that's coming at a cost of educating ourselves about the tools that are in, like, about the RTM. So that was the reason that I did a simulation and also project-based learning for the students, and telling them not only use the student as a clinician needs some learning, but also in the simulation-based scenario, you should equip your patient with the ability to work with the tool independently. So that's something. So rather than being a passive consumer of technology, we need to learn to be active. So the last takeaway is human oversight is remaining essential. So that means that there's always a need for professional judgment, and that is irreplaceable. So the most important question is not, can AI make decisions? No. The important question is, how can AI help therapists to make it better decisions? So that's the question. So final message is the future of rehabilitation is not therapist versus AI. Is the future is therapist with the AI. So that education does matter very much. Clinical reasoning, also literacy does very much important. And those who understand how to combine the technology, evidence, and clinical reasoning, they would be best positions to improve the patient outcomes. All right, thank you so much for the listening. So these are the references and resources. A couple questions for the questions and discussion. So these are the questions that I want to ask the people. So if you can like do your best to answer uh, for example, is what you learn about what unique value does the PT provide if AI can monitor every repetition? That's my first question that I hope everyone understood it from my lecture, from my presentation, the webinar tonight. And also, how should PT education evolve for AI-enabled practice? So if you were able to type in the chat, I would appreciate it. If you want to talk about it and then answer these questions, that would be also so great. So I leave that conversation to the people.
Thank you, everyone, for being here. Please use the chat feature, or you can unmic if you just want to talk to us. You don't need to be shy. We're a manageable group, so we can converse with you.
This is Liz Scarpelli.
Thank you, Liz.
I've taught in the Kaiser residency program for over 20 years and have monitored many students. And my concern is I think they're still having difficulty with clinical reasoning. And I think a lot of times what happens is they get an idea of what the pathology is. This is not necessarily for, a total knee or a total hip. Those are pretty straightforward. But I'm talking about the patient who comes in that's complicated, and you have to differentiate what is the patient there for and what are the extenuating circumstances that get in the way. And I'm not so sure that unless they have that, they're going to cede it to the AI. And that's what I worry about, is missing some of the big picture.
So what I can tell you is AI is going to provide, like, if you were use AI in terms of like RTM in between like a sessions, like a Kaiser, how many times how many times in a week do you visit your patients? I mean, typically.
Well, I was instructing, but when I was there, the students would see a patient twice a week
Okay.
for
So
45 minutes.
45 minutes. So think about like how many minutes they're available. How many minutes? I'm guessing that that was a one-to-one model. And
Mhm.
so compare it with with the RTM, AI powered RTM, that it's extending to the home. So you can have a tool like a motion analysis tool. You have a tool that can collect some like extra information from home. Still, it
Mhm.
has on its own limitations. It's like
Sure.
it's also like in terms of like clinical reasoning. Think about like you're the one that is posting some like a balance assessment to your patient. AI can recommend it to you. Like if, for example, you can do a single leg stance assessments or Romberg, for example, or others,
Mhm.
but you're the one that is making a decision. That's first of all, that's the first important thing. But
Mhm.
when it's posted to your patient, you can repeatedly check the assessment, for example, for the fall prevention at home. So that is not available when they are in the clinic because you have a limited time. But you have
Right.
that accessibility in between the visits. And you can also look at other parameters. You can come up with other parameters. Also, you can be creative also that may not be like AI is able to do it. But technically that's another like eye that you can borrow and you can have in the time that you're absent. And I
Mhm.
agree, like a clinical reasoning is a long story, but and then having more data does not necessarily mean a better clinical reasoning, but it
Right.
may help, it may assist us. Uh, and AI is also do some insights that over time may help.
Mhm. Thank you.
Cheryl Flynn, welcome to Webinar Wednesday.
Hey Rita, thank you. Thank you for that presentation. I found it really interesting. And as you may or may not know, I'm a physical therapist, but also a software developer. And I'm kind of considering adding potentially some AI to our platform. I know that that brings with it a whole bunch of FDA regulations. And so it's sort of a big heavy lift. So we haven't dipped our toe into that quite yet, but I have several questions. I'll just ask one, and then if somebody else doesn't have a question, I'll ask another one. Um, so I'm kind of thinking, and it's been a long time since I got my PhD in motor learning, motor control, so things have probably changed. But I remember about the importance of learning with errors and
Mhm.
like BCBA with people with autism, there's this whole concept about errorless learning, but the importance of kind of learning and then correcting and kind of having some autonomy about that. So while I think that you brought up like many really interesting I don't know, concepts for me to kind of think about. It's going to take me a long time to think about your the conversation today. But I just wonder about motor learning itself. And like I'm looking at this scenario that you have here where the adherence is 92%, pains increase from 2 to 5, knee flexion range of motion has improved, squat quality has declined and weight shifting has increased. Would you progress the patient? First of all, do we need AI for that information? Like that can be a summary of what they've done. And then, would you, I guess the same question twice. And then, what additional information would you want? Yeah, I guess I'm just sort of thinking like, what is the role? And by the way, my software is an RTM. Like that's one of our focuses is on remote therapeutic monitoring. So, what information is important information to display to the clinician and how much of the feedback do we want to give the patient related to actual performance?
Mhm.
That's a really messy question, and I
I
apologize.
know.
It's late at night.
Someone gave it to me. I was like,
Um,
look at my notes. This is what I have from you. I was like, oh my God, that's a sounds like one question, but technically there are four.
it's yeah,
Uh,
it's
yeah.
several, and I apologize for that. But yeah,
So think about it this way. One question you asked me about that specific case. Do you need AI? Yes. because the patient is not in the clinic. How do you monitor? Definitely AI. There's no other way that you can do it. So AI is the camera, so it's going to be act as a motion analysis system for you, and it's going to be also telling you like posting the exercises, quantify the performance for you. So you need AI. That's because this is a hybrid care. So what I
Oh, I
was
see.
setting up
Yeah.
the scenario, that was
The
hybrid. It's
sensor
not
is
in the
important.
clinic here. So
Hmm.
that should be clarified. This is all about RTM. This is all about continuous care,
Hmm.
not discrete care in one visit versus the other. So that should be clear. So you need AI for in between visits because you're absent. So that's one thing. You asked me about what additional information for that unique case would be best. So think about it. You have information about range of motion, quality of the movement. So you can always qualify, like a kind of like change the quality of a movement by some like integration, like a type of measurements. So leave it to your engineer. They can better understand it. But like if you predefine some compensatory movements, compensation or like a deviation from the correct form of doing one exercise, there are always some measurements that they can come up and they quantify the quality of the movement. This is more like at the like mathematical level. But you would qualify like a quantifying, and also you were actually like a check the quality of the movement. So you have the consistency. So now your question is that what else I can collect? What do you think that you can collect? So you have range of motion, quality of a movement, adherence for that case, but still you don't want to progress or not. What do you think should be the answer to this question?
I mean, I guess I think about it more in terms of like functional activity, like
Mhm,
which activities are they having pain with? Because their range of motion is increasing. Yes, their squat quality has declined, but I don't even know what declined means.
mhm,
Weight shifting has increased. Have they weight shifted? I mean, maybe I know this is just an example, but have they weight shifted onto
mhm,
their knee, their leg that had the arthroscopy, or like, are they now starting to move towards putting more weight on the knee that has whatever issues going on here? Or
mhm.
TKA, sorry, I saw it at the top now. So I think I'd probably need a little bit more refined information, but for me, it's about functional activity. Like if you learn how to perform the perfect squat and you have one motion,
Mhm.
then what happens when you're skiing, or what happens when you're, reaching for the thing that's underneath the sink that's you know, you're in a different kind of squat situation.
Right. So think about it. Um, Probably you need to post more functional assessments for the
Hmm.
patient, and
Hmm.
then ask the patient to more going through some of those assessments. That could be also, or you can post some more difficult exercise and give, because this is more like a generating hypothesis if
Hmm.
in terms of like clinical reasoning. So if
Hmm.
your patient is progressing with a good SCOT, pain is like enough, good progression in the range of motion. Now you want to decide about like a progressing or not, but then the question is that what type of like a functional tasks are best to post and decide. So that's one in terms of like assessment. The other thing is maybe like thinking about like those exercises that are easier, for example, in the plan of a care, in the hip, that should be eliminated and then replaced. So then you can keep going and see better results in the scots. The other piece is maybe you are at the range of motion that is enough for the post operation, for post total knee replacement, but
Hmm.
you want to work on other, like kind of like stretching the muscles. You want to work on other goals. So the patient goals does matter also here
Hmm.
very much.
Hmm.
So they want to have a better functionality, because for the surgeon, the range of motion functionality, some specific functions would matter first line. But
Hmm.
you as a therapist, regarding the patient goal, should set up some other functional assessment as well. So these are all can be aligned in with the AI. And also AI is again like giving you insight, but you are the clinical decision maker. But you can think broadly through that.
So like in this situation where it says knee flexion improved, but the squat quality declined, like maybe they're learning how to do a deeper squat. And so
Mhm.
maybe the quality is not great at the beginning. Maybe, because clearly you're going to see, I would imagine this is an ortho outpatient setting. You're probably seeing the patient once a week or twice a week. So are they able to do a deeper squat, but they're still weak or they're still, they're still sh weight shifting off of that leg or something, but they're learning how to do that squat, then I wouldn't necessarily um, change anything if I see at least that they're moving in the right direction. Because when you first do it, as you go deeper, it's not going to look pretty necessarily, right? As you
Mhm.
gain the range of motion and your strength is not there through the full range of motion. So, anyways,
That could
I
be one thing. It
mhm,
very dif it very different also. Some softwares it define the movement quality differently than the others.
mhm,
So you should kind of like ask how they are predefining the movement quality.
mhm,
So they may consider all of the joints, they may consider some of the joints, or they may
mm,
consider only like few parameters. So the
mhm,
movement quality can be reflected out of all of those. So that's something like a movement quality is lower, but when the movement quality is lower, there's something wrong. Maybe the patient is compensating to some extent with like a trunk leaning, for example, or
mhm,
they are using a for example, kind of like a like a kind of like a heap like a that is like a shifted backward, for example. So it's not like a correct form of that. For
mhm,
the Scott could be also it again like very depends on how they're predefining the movement quality.
mhm,
Could be larger base of support, like distance is included in the assessment. It very depends on that.
mhm,
But that's a good case to think about it when
mhm.
you have an access to the large data set.
Thank you. Appreciate that. I don't want to hog up all the time. Appreciate
Yeah,
that.
that's
Dr. Granado, welcome. How are things at Western University?
Oh, fantastic. Thank you for asking. Uh, I'm still trying to um, properly formulate my question. I mean, I'm old enough to remember that I used phones that were connected to a wall and I had to use a payphone. And my feeling is, while I do recognize that AI is uh, a future that we are having to incorporate currently into the current landscape, my question is this, I think. How does the current generation of students and going forward coincide with this future of AI? And I think what I'm trying to get at is, um, I'm wondering with students, and I acknowledge that with Elizabeth saying that the clinical reasoning is a bit of challenged, and it seems if I maybe it's even worse today, I think. But having said that, I'm wondering, do you think in your presentation and your research, do you think maybe this generation needs AI, which might, it sounds like it's a crutch, but do you think AI, because this generation is so used to using technology, do you think the use of AI might even elevate their skills, their performance, their abilities even higher than where we're at, even though maybe their clinical reasoning is a bit flawed or hampered, currently in the early stages? Just your thoughts on that.
I totally understand your concern. I totally understand that's also a great question. Like if AI is although like right now AI is not that like showing all of its capacities. It might be different next year and the following years. So it might grow to some extent that give a better recommendation to the people that are not deep into the clinical. I'm not saying all of the therapists, but those therapists that are technically like in the low level, kind of the clinical reasoning always, and then following some routine things rather than thinking and evaluating things deeply. So it might like exceed their skills and do better insights and recommendation. It might. I'm not sure about it, but overall, I think AI in our field, because we do a lot of things in the clinical visits, which AI is technically absent. It can, I mean, it should be absent. It is absent. I mean, MMT, those things, they were never replaced, at least with the capacities that we see from AI in the near future with MMT. I mean, technically they are absent. So AI, I think, is gonna be a complementary and assistive device for us in the long run because it can fill up the gaps when we are absent that is in between the visits. But when we are here in the clinic and we are extending our care, so we are adding up like things that we learn from the objective assessment of AI after the visits to our kind of like inputs and understanding from the clinical visits in the clinic. So technically it's assisting and extending the care for now, for right now that I'm talking to you. I don't know about 10 years from right now. Maybe it's going to be substituted also in the clinics to some extent. I have no idea. But for now, it's more like extended care because we're still holding a clinical visit that are uniquely defined to the tools and also the knowledge that are not within the capacity of the AI these days. But I think it's optimizing it, and it's not for the students ended up into the easier clinical decision because there are going to be more data and then expecting over time that technology be inherent in their clinical cares over time, maybe like in the 4 or 5 years, or even like a closer patient may ask like, do you have a HEP? Can I do it on the phone? So, but you cannot just leave it like on the phone and then they're going to complain. Go to another therapist that can look at their HEP and then give them a better recommendation for the home exercises. So that is the expectation that may come from the patients. Maybe not the like a very like a old generations, but maybe like a recent generation, like people who are around 65 or around 70. Right now, they have a good technology, skills for using that. That expectation may come from the patient. And if our students are not ready for that, so then they might go to whoever that can add us, like a wellness centers. Like wellness centers are right now, they're very tech-based, interesting in doing it. But overall, I think clinical reasoning for now with the AI capacities that we have right now, that is extended care, is not like to some extent, it's making it easier with the AI insights, but it's not actually like thinking less. It's thinking more because we need to also teach them how to look at the range of motion assessments, which is technically absent in a lot of our schools' education these days. We need to teach them to look at the trends and infer from them. We're not training our PT students to be objective these days. We're training them to be very subjective. And that's going to make it trouble. And then we need to educate them on doing that. So it's not thinking less for this, for clinical reasoning right now. But I don't know about the future.
Thank you.
Mhm.
A
Thank
question.
you.
So what patient demographics benefit from RTM? I know you mentioned total knee, low back, fall prevention, but what actual demographics? Like who is most likely to be compliant with this?
So based on these studies, there's some factors. One is the like being able to kind of like cognitively or like being able to use the technology. So technically, like like in patients in the like acute care, neurology, they're not able to use or benefit from the technology. So that's going to limit them. In the musculoskeletal care also, if they are within the geriatrics groups and they have a limited capacity for the use of like technology, that's also limiting factors.
Right.
But other than that, even like I was in a conversation with a group of people about the pediatrics, like those who are able, like right now, 10 years old, like kids are able to use the technology with the help of their parents. So if they have, for example, like a scoliosis or not a scoliosis, like any kind of like a developmental, like a MSK, musculoskeletal disorder, so they may benefit from that.
Mm,
But I think the AI literacy is the most limiting factor. AI kind of like capacity for using the technology. The other factor is the like cognitive restrictions,
mm,
if they exist.
I see. And do you have patients go through like a pre-training for RTM, or is it how do you? I'm just wondering, how do you actually know who to give this to? And
This is based on the literatures published. Like most of them are musculoskeletal cases.
mm, okay, thank you.
Mhm.
All right, I hope we have time for one more question. Elena, you've been patiently waiting. Thanks for
Uh,
being here.
Thank you so much for this interesting talk today, Dr. Salsabili. My question is regarding
Before,
the
sorry, before answering your question, I would be happy to do that simulation-based education and also project-based education in your schools. So this is something that I'm offering also to the people in the UCSF, and then we are working together around those. So anyone who is a faculty here and would be interested in doing some kind of like a clinical reason about how our teams are working and also want to have some like that like education in their course, I would be happy to work with them. Sorry, Elena.
Thank you.
that's fine. I think that's great information. Uh, Regarding the data
Mhm.
that's coming into the RPM, the old adage of garbage in, garbage out. The wearables and the video that these programs are collecting, all the ones from this particular program that you showed us are incredibly fit people with very easy lines to delineate their ranges of motion. But I think we all know that the patients that are usually most complicated are the ones that present differently. Are your obese patient, or your patient with other neurological involvement, or your patient who just can't get the monitor on right.
Mhm.
So I'm curious how the field will overcome these types of limitations.
Mhm. Mhm. So getting back to the question about the like how AI powered HEP RTM works better for which population. So if they are not able to like kind of follow the instructions or maybe like adjusting the cameras, for example. So nowadays adjusting cameras is like way easier because the models, the AI models are very much capable in detecting the landmarks. Even for obese patients or pediatrics are also like included in the models. They're very capable in doing these two groups, as far as I know. But that like a limitation in working with the technology. Those people who are like in the groups that have a hard time, like even for adjusting the camera, that's something. The other piece of that is again like a literacy. So both of our clinician and also our patients need education. So when you are teaching them in the clinic about, for example, one home exercise, so maybe like a few minutes of like showing how to work with the technology, how adjusting the camera, how to start, that's enough for educating them. But as long as like you're kind of like sure, this is the same as like when you want to teach your patients how to use the like the I don't know, like a um, treadmill, for example. Just one example. So we spend some time with our patient to teach them which one is the speed, which one is the inclination, how to manage like the time. This is the same thing. And then now it's very much like designed to be simple. It's still not as simple as working with the treadmill, but some level of education around that would be needed. If someone was not able to uh, get like the idea of how to work with the technology, even if it's very simplified, so that's another kind of like a limitation these days. And that can be maybe like for the older ages or people with the cognitive or mental restrictions, or like, I don't know if I answered your question. There are multiple factors actually, like different layers around that question.
And so one would assume then that those client populations, once we've assessed that they're just not interacting with the technology appropriately, are not appropriate for RTM. Is that the
Again, it's a hard answer. It's a hard answer to to a question. First, you maybe like you need to rule out, did you do enough education? Even if like think about treadmill example that I told you. If you as a clinician trained enough about to look at your dashboard and then pass that information. So these are two pieces that you need to rule out. Then the next step is knowing about the literacy of your patient. If your patient is able to work with the Surface Pro, so technically you're assuming she's able to work on like adjusting the camera and do the RTM. If she's not able, so maybe there's another layer or there's another reason for doing that. So I don't know if I passed that message. So you need to rule out few things before excluding someone from the RTM, AI RTM.
Thank you. Appreciate it.
Thank you, everyone. We're at the top of the hour, so out of respect for your time, we'll try to close this webinar up. Next week, we have actually two Conant webinars being offered. On June 30th, we have a think tank where we are going to be discussing the topic of, trying to think how to phrase it. Can you provide quality care in a high volume setting? So does one have to do with the other? Then we have Webinar Wednesday on July 1st. The topic next week is the PT's Guide to Muscle Preservation in the Age of GLP-1s. So if you have patients who are taking the GLP-1s, are you up to date on the impact that those drugs are having on their musculoskeletal system? If not, join us next Wednesday and Dr. Linda Brown will get us up to speed. The CPTA website is always your best site and location to find out what's new and coming. So let me know if you have any questions. The course evaluation was emailed to you at 8 o'clock. So look for that. Give us your feedback. We are booking webinars outside of Wednesday. Wednesday has filled and there's still a lot of demand and interest. So we're offering some courses this fall on Tuesdays and Thursdays and Monday nights. So we want to be your go-to for all the topics you want to hear about. Dr.
Last point, I left my email in the chat, like a box in an inbox. So anyone who is interested for educational collaboration, I would be more than happy. I am still learning from my students through those two like educational projects with the students, and I would be happy to learn more and pass that learning also to your PT student, DPT students.
Thank you. I know we have UCSF and Western in the house tonight, but others may be adjunct faculty or have connections. So we'll get the word out for you.
All right. Thank you so much.
Everyone, I'll send the video recording tomorrow, and it will also have Dr. Salsabili's email on that too. So grab it tonight or get it tomorrow, or let me know if you need it later in the week. So have a good evening, everyone. Be safe.
Thanks. Bye.